Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is the future of rural health. My co host and moderator, Dr. Dan McCarter. Dr. Dan, how are you doing this evening?
I'm doing great, Faisel. How are you?
I'm doing really well. I'm so thrilled about our friend that we're going to be having joining us tonight.
Absolutely. Rural health is near and dear to my heart. I love to hear what his plans are for that and happy to take questions in the chat as we go along as well.
Yes. So without further ado, let's welcome our friend for the evening, Dr. Phil Polakoff. Dr. Polakoff, thank you so much for joining us.
It's my honor and privilege. Thank you.
And so I'd like to know, just before we went live, we have something in common. You and I were both born in Brooklyn, New York. I am now living in Tampa, Florida. After doing my training, I joined a large federally qualified health center in Tampa. But we want to know, how did someone from Brooklyn become so passionately involved with rural health?
Well, it's a longer story than I want to go at length on, but nevertheless, I grew up in New York, and then I went to Cornell in agriculture and was going to be a vet, had a little detour, a pivot, and then went on to get an engineering degree from Rutgers. And from there, went on to medical school and was involved in the race riots in Detroit in 1967, then went on to train overseas in the National Health Service at Oxford, and then came back here and was a commissioned officer in the U.S. Public Health Service with the National Institute for Occupational Safety and Health, and traveled throughout the entire country, from the Appalachians to the South to Texas, even Virginia and other places. And from there, my entire career was engaged in both public health, preventive medicine, and clinical medicine. And I was shortlisted during the Obama administration to be Surgeon General. I didn't quite get it, so be it. And then Stanford University asked me to come on board as a consulting professor in the School of Medicine and affiliated scholar in this Bill Lane Center for the American West. And we put on our major first forum in Santa Fe, New Mexico. And from there, I got involved in rural health. And ironically, to complete the cycle, last week I was filming a movie in New Mexico on rural health, and we'll share with you that shortly. So from there, we went throughout this entire country and saw the story about what should be but doesn't exist in rural America.
I can't wait. We're going to do something different tonight that we haven't done before. We are going to share a presentation. So producers, Drew and Jess, let's get the presentation put on. Here we go. And we'll let Dr. Polakoff share his presentation.
Sure. And as I always say, let's make this as interactive as possible. If you have a question, let's just stop and hear your question. A better future for rural health needs scaling of the action. We just haven't had enough action. Let's go. We can go pretty quickly. Just move along. Next slide. Rural health. If we go back to the future and use the World Health Organization of Health that was created in 1948, rural health is a state of complete physical, mental, and social well-being for one and all, and not merely the absence of disease or infirmity. Unfortunately, most of the concentration is on the sick care model at best, and it deals with physical health, and seldom are we addressing the mental and social well-being. Next slide. So when we look at some of the key facts, 60 million or more people live in rural America. It's both going up and down since COVID-19. The more affluent people are moving out of the urban areas and going to the destination resorts, whether it's Jackson Hole, it could be Sun Valley, Aspen or Lake, or in my area, it's Lake Tahoe. But the 60 million people who reside there take up 40% of the geography of this country and get very little of the resources. Since 2005, 172 rural hospitals have closed, and numerous nursing homes and senior citizen homes have gone down, and more are on the way. There's a real shortage of all providers, just not physicians. It's hierarchical. The specialists want to stay out of there. Psychiatrists want to stay out of rural America. There's just not enough resources. The people want to serve, but the resources are not existing to the fullest degree. We also have a technological problem. The broadband and the internet connectivity are often limited and need upgrading. COVID-19 has had a real major impact on rural America. Some has been slightly positive, the access to telemedicine, telehealth, and now the latest, if you haven't heard, drones are coming into rural America to provide services, delivering of healthcare pharmaceutical agency are going through by drones. However, the flip side of it is many of the people who got affected were either people working in meat processing, the Native Americans, the people who were in nursing homes, and prisoners, the incarcerated. So the death rate was off the wall. And there's a challenge because to educate, the public health community was not very strong before COVID-19 and just got worse and worse. Politics played a major role rather than, as you were saying in your opening remarks, healthcare really should be a right, not a privilege for one and all, but we got a ways to go. And then there's a growing rural-urban gap. Most of the money that goes into the resources goes more into the urban environment to the rural environment. So these are the facts that are on the table. When we go to the next slide, you'll see that currently, and this is a big issue, and Faisel, you know, you and I are buddies, so I don't know if we answered the question about Brooklyn, but we came up out of New York together, and you went to Florida, and I moved out west. But when we look at the federal rural programs, a great deal of money is being spent, but it's fragmented, inefficient, and ineffective. Right now, there are over 400 programs, and they're sparsed all or delivered or shared all over the place. There are 13 departments, whether it's health and human services, it could be commerce, it could be ag, it could be transportation, you name it, homeland security. There are 10 independent agencies, 50 offices and sub-agencies, and 14 legislative committees. It's all over the map in the Congress. You have senators from rural states, you have people that congressional representatives from rural states, how well they work in team. And there also continues to be what I would call a right-left divide. And I would rather see us go from past to future rather than worrying about, because it doesn't matter if you're a Republican or a Democrat in Mississippi, Kentucky, West Virginia, you still have the needs of the people that have to be served today. So it has to be bipartisan, innovative, and collaborative. So with that, a dream has come true, and the next slide will show you the dream. The dream, hopefully it shows up, shows you the current state, today's model, which is chaos, whatever you want to call it, can go on. And the new model, which is being presented to the president next week in a letter from our two sponsors, Senator Ben Ray Lujan from New Mexico and Congressman Anna Eshoo from California, is hopefully simple and elegant. It doesn't exist today, and we'll see where we go with it. But basically, it'll be bipartisan or nonpartisan. It'll be housed in between the Department of Health and Human Security, Health and Human Services, as well as Ag, because those are the two major players. It will then reach down to the state, and then it will go down to the community level. So it'll be something from top to bottom. When we flip the coin onto the next slide, you'll see a different thing. Moving forward, we have to scale the action now. We have to lay the groundwork. And what we need to do differently today. It cannot be the same. So let's see a different model. Last week, next slide. Last week, I had the opportunity of going to New Mexico, the northeast quadrant of New Mexico, which is absolutely physically beautiful, but poverty-stricken. However, they have a new initiative there called the 100% Initiative, and they put forth what they call the 10 vital services. On one side, it has to do, actually, it should be striving and thriving. So on the striving side, it's immediate medical care, mental health care, food security, housing security, and transportation to vital sites. On the thriving side, it's parent supports, early childhood learning programs, community schools with health centers, youth mentors, and training tied to local job creation. So this is bringing people together, and they start this out with a book club, and they bring out all the players in the county which got 24,000 residents.